good morning, good afternoon, good evening, as the case may be. I am Madan Rehani, President IOMP, and I'll be moderating today's session. I welcome you all to this last webinar of IOMP this year. We'll be back next year, and we will give you the announcement later on that. Today, there is a very interesting topic of patient dose and patient-specific dose. Whenever I talk about the patient dose, I say dose, but where is patient dose? We have dose to the phantom, we have dose to the entrance dose or skin dose or various dose metrics, but where is patient dose? That remains a question. To deliberate this subject today, we have a very highly acknowledged professional, Professor Hilde Bosmans. She is team leader of the medical physics experts in radiology in the University Hospital of Catholic University Leuven, Belgium. She is also the team leader of more than 100 centers in Belgian breast cancer screening. She is also professor at the university with a team of PhD students and postdoc researcher. She works at Dose and Quality in Radiology. She steers project specific dosimetry, and she has the theme of several successful projects on this topic. There is a company, Qaelum, which many of you may know, that develops and commercializes a dose management system. And that's a spin-off of the department which she leads, and she has involvement in that. She was the leader of the EUTEMPE Diagnostic Radiology courses project, which was awarded by the European Commission for medical physics experts in radiology. And she's continuing to steer that project after completion of the project by the European Commission. With these few words, I have great pleasure in inviting Hilde. Please, Hilde, you may start. Looks good.
Okay. Yes, thank you very much, Madan, for this nice introduction. But in fact, first for the nice invitation to speak here with such an amazing group of people connected. I feel like a small musician in front of a big, rock festival situation with, several hundreds of people connected here. I thank you very much for this opportunity. The title, as you said, of this presentation is Personalized Dosimetry for CT and interventional procedures, and I will actually add also a little bit on chest X-ray. Okay, let's start. I would like first to acknowledge several people from whom I have copied their main results of their PhD manuscripts into this presentation. You will see some of the names flashing up during this presentation. I have also a disclaimer. As Madan already said, I'm co-founder of this dose management company, Qaelum, and okay, the product is installed in our hospital, and that is where I get the graphs from, obviously. Here is the overview of the presentation. I will first set the scene, and then I will focus on 6 applications and end with a discussion. I hope that is fine for you. Set the scene. Why would we want personalized dosimetry, or better, what is personalized dosimetry? And when I started my career in X-ray physics, specifically X-ray physics, I started before in MRI, but around the 90s, I started also to work in X-ray physics. The big boss of our department at that moment said, you know, what has to be discovered there, everything is in the big books. We know the doses, they are type of fixed. And a first approach to patient dosimetry could indeed be like see what is the typical dose for a particular exam. Obviously, with personalized dosimetry, we want to go a step further. But already this first approach, finding out for a particular exam what is typical, is probably a very good first indication. But in this presentation, as I said, we are a little bit more ambitious. So a next step is to apply conversion factors on measurable data from patient examinations. For instance, I hope you are all familiar with concepts like dose area product or entrance skin dose or the CTDI in a CT scan. Well, after every exam, the patient has an amount of exposure expressed in DAP or Ssde, and to this amount of exposure, we can apply conversion factors to get then a more precise effective dose of the patient. You can find these conversion factors. For some examinations, it may be a little bit more difficult to find them. I like a lot these NRPB documents, which are pretty detailed for different types of examinations and different types of conversion factors. Let's go a step further. We can also try to calculate an effective dose using, you may all know, or I presume you know, all the organ doses weighted with the radiation weighting factor, so 1 in this case, because we are using photons. And then we can add to these organ doses the tissue weighting factor. We add them up by this summation and we get an effective dose. Okay, a first approach to get these organ doses can be found from, for instance, commercial software packages that calculate these organ doses for us using specific models. And this is just an example of the CT Expo program that we, by the way, like a lot. We have been working with this during a long time, so I don't want to criticize the program at all. But in this program, you can find typical organ doses, radiation-weighted organ doses in the different organs for a particular CT exam for particular models. A next step in more personalized dosimetry does not evaluate these organ doses for the model, but tries to evaluate these organ doses for the specific patient under study. And that is, I think, a next stage into personalized dosimetry. And finally, here is an example how this would work. For instance, you start from a CT scan of a patient and you segment all the organs. You do then the Monte Carlo simulation of the model that you have created of your patient to obtain the organ doses, and you add them up with the tissue weighting factors. And then final next step is then to start from these effective doses and make them more patient specific by bringing into this framework also the risk. Also, again, I think 2 stages, either what we know here from the global effective doses that normally to get to the risk, we use a standard conversion factor. But if we, for instance, want to make it a patient age specific, we can go to risk using the attributable lifetime risk in percentage per sievert that is applied on the effective dose as we just calculated. But it can also go even more into detail, cancer or organ specific, and for males, females separate, and even as a function of the age of exposure. This is therefore a type of a multi-step procedure. And in this presentation, I will mainly focus on this part, try to improve the effective dose calculation by trying to get as close as we can to the real organ doses in the patients. But I will not address this risk, further risk study. There are other people with more experience into this. Okay, but why would we want to do this? And there are, I think, for sure applications where everybody agrees it is good practice and it is in the meantime common practice. For instance, if you want to know the effective dose of a child, you will probably, hopefully, look for other conversion factors or other computer programs than if you want to evaluate the effective dose of adults of the same exam. Maybe you want to differentiate for the weight of the patient from thin to obese, or you want to differentiate men, women. There are several applications where that is also important. Or you want to go even more into detail and differentiate as a function of BMI, because not all patients have the same fat muscle distribution. But there are other ways where we can maybe prefer more a personalized approach. You may want to specify or to go specific for the device that has been used. Or you can maybe want to improve as a function of the different positioning techniques that have been applied. For instance, if this is a chest X-ray of a premature child, okay, you would want to pick a conversion factor for this anatomical region. If, however, the child did not get a chest X-ray, but a total abdomen scan, you want a different conversion factor. Normally, both should be differentiated in the DICOM header with another type of organ, and you could differentiate, but it requires some more detailed study. Of course, all these specific organ doses, they are not just at this moment available for all the patients or all the situations you have in mind. At this moment, we still need a working plan or research to solve many of these questions. And maybe it is in fact an ongoing research, because by the time you have finished with the normal CT scanners, there may be a new CT scanner on the market or a new option on your interventional radiology or cardiology device. So, in fact, what we have still to do today is to develop tools and then use them, for instance, to differentiate or to go specifically for pregnant women, for the weight of the patients. This can be important if you have high dose cases. Maybe for these high dose cases, you want to look more specifically where this high dose comes from, or you may need it to explain incidence, or you may need it at the moment that you want to introduce new devices or specific applications on specific devices. Personalized dosimetry may also allow a better individual risk estimate, for instance, at the introduction of new technology, or you could use, and we will show this a little later, it can help in outlier alerts and dose management or for focused optimization. So there are several reasons, and that is why I suggest that I show you just a few applications. Let me start in mammography, because that is the domain I work most of all in, and their personalized risk assessment is pretty well developed. For every mammogram, we, for instance, aim to calculate the mean glandular dose. If we use the dense model, but in fact the American model is pretty similar, but for the dense model, we would start from the incident sarcoma and then use 3 factors. And some of these factors, the G and the C, depend, for instance, on the thickness and also on the density of the breast. It remains still ongoing research with, for instance, the APM-EFOM task group 282. But if we then make our dose graphs, you see here the thickness of the breast and here the mean glandular dose. Every point in this graph represents another mammogram and is the result of a personalized calculation in which the thickness of the breast has been taken into account, and for the density, either a statistic average was used or the patient-specific density value. Both approaches are possible. We can push it even further, and here I show you a slide with some earlier research in my team by Nausicaa Gerard. And she has studied the compressed breast thickness as a function of density for 3 different regions in the world. And then she could, well, these graphs could be checked to find out where a specific patient is compared to this distribution. But taking these personalized characters into account, it was possible to calculate the overall accumulated doses in the different populations. So even in mammography today, we do still efforts to make it more personalized for everybody. Let me switch in a second example to the chest X-ray room, and you may wonder, why would we have to check this? What can we gain there with addressing this personalized version? Well, what you show here is an overview in one chest X-ray room in our department. And you see that most of the exams are within a certain range. There is no problem here. We see here in the sky a few very high doses, but I've colored them in red because these are usually when the outliers are that high out in the sky, in this black sky here, it is most often the consequence of a wrong image that was taken, or a wrong DICOM tag at some point. So these we can probably simply neglect. But here, these cases here are a little bit different because they're just high and they may represent just the obese patients. And with obese patients, it's not a problem that the doses go high. But the trouble is, maybe they are obese, it's not sure. And in fact, here it would be very good if we could, out of these outliers here, know upfront which correspond to obese patients and which are basically the errors on the normal patients that we should detect and why we do dose monitoring. So we have decided to focus on this, as we want, in fact, we had two aims here. Make sure that obese patients do not show up as outliers, because we know with normal conversion factors, we would overestimate the dose, and maybe these patients here just belong to the normal category. There is a recent publication in 2020, Medical Physics, that gives us a part of this solution. And what these authors have done is they have calculated first for the different weights of the patients, what would be an effective diameter of a specific groups of phantoms. And they could correlate specific models, specific phantoms with weights of concrete patients. And then they have calculated the Monte Carlo conversion factors of the phantoms that correspond to specific patients. And they made, in fact, conversion factors as a function of weight. And here you see their graph, conversion factor as a function of weight, that we can then now start applying to our patients. One of the nice things in their graph is that for different types of examinations, plain chest as well as CT chest, for instance, these graphs are like parallel to each other, which is reasonable, I think. And we see also that indeed the conversion factor that you should be applying for, say, or let's make a bit more realistic, 20 kilo versus 60 kilo patients, well, there is a significant change in conversion factor. So if we go back to the previous slide here, as a function of thickness, if these patients are really obese with a proper conversion factor, their effective dose will be tuned to a lower level. But the problem is that most often we don't know the weight of the patient. And that's not only the case in our hospital, but that is what we hear from many hospitals. And so we came up with a scheme that is being worked out in a PhD project. Most of the papers are on their way, hopefully, to get published. So this is a scheme which hopefully will lead to an automated correct conversion factor for chest X-ray, even if the weight is not known. And it starts, in fact, from the incident air karma and also the detector air karma, which allow to calculate total attenuation by a specific patient. We can convert this to a type of water equivalent thickness. We have proven this. I'm not going to give all details there. We have proven it, it works. And so if we have this water equivalent thickness, it's possible to calculate conversion factors for chest X-ray for the chest X-ray patient. And it seems to work. Personalized risk assessment in CT is very important. I agree it is probably more important than for chest X-ray, but both I think are in very good study topics, and they are also type of related. Here the concept of water equivalent diameter and size specific dose estimate is going to help us. This is an approach that has been worked out by the APM, and it is very nice. In fact, for every patient, a cylinder is calculated that absorbs the X-rays like the patient would do. And then for this cylinder, the relation with the CTDI of the 32 centimeter cylinder is being calculated. So if we measure in the 32 centimeter cylinder, the CTDI as is shown on the screen, there are tables that predict what we would measure in this cylinder if the diameter is different from this 32 centimeter. And that is what we see here. And as the dose is pretty homogeneous over the cylinder, and this patient is represented by the cylinder with CTDI, this conversion factor, we can get pretty close to the organ dose in the patient. With dose management systems, it is possible to calculate the size-specific dose estimate, and you see an example here. Obviously, we hope also that CT manufacturers come up with this Ssde as soon as possible. This whole concept of using Ssde into routine practice and then go from Ssde to effective dose, this is work in progress and has to be completed now for all organs, not just for chest and abdomen. I know that the work for CT of the brain that is on their way, and for children as well. So the opportunity is here that it can be calculated from CT exams if the images are sent indeed to a dose management system, and sooner or later it will also become available, I think, by the CT scanner manufacturers. There is an alternative approach or an in-between approach, and I'm here grateful for Sochil who worked this out, which is as follows. If you have the true Monte Carlo in-house for the specific scanner of your interest, then it is possible to use that as gold standard and see whether you find software packages that come close to your truth. And that is what Sochil has done here in her study for a group of patient models that she had segmented starting from real CT scans. And she has calculated with Monte Carlo, for instance, the dose to the breast, and then also the dose to the breast by other parameters. In the y-axis is here always the gold standard, and on the x-axis you see her approaches with either commercial packages or with the Ssde. And we see here that the correlation is pretty nice, but it's not perfect. The perfect correlation would follow these dotted lines. Of course, once you see this, it is possible to correct yourself. But it is not always as nice. What you see here is the gold standard dose to the lung versus different other solutions, more easy solutions that do not require a Monte Carlo. And here you see it keeps on correlating very well. But if we switch to the liver for a CT exam of the chest, you see that the deviations are larger. Of course, with this, I don't want to say that we should be doing Monte Carlo for every patient, because this is simply not possible, but it can help us develop more easy tools. And this Ssde here is for sure a very nice first or next step. Another example for personalized risk assessment is in cone beam dental CT. And here I would like to show you the full effort on how to address this. Here we go, specific for pediatric cases. There were no models, as far as we knew, with the detail required for the dental exams or for the dosimetry in dental exams, such as salivary glands and thyroid and all these other organs in the head of children. And one of the main problems was that, we wanted to start from the CT of the children, but we wanted a complete CT of the head including the thyroid and so on. So it was difficult to find the scans. And then it was a very huge challenge to make models with all the organs of interest. And Andreas Stratis has at the end done it for different ages. And then he verified very carefully then the different sizes of all these organs. Then the next step was to adjust a Monte Carlo platform to a CBCT system, which was another challenge. And then the next challenge was to do the Monte Carlo organ dosimetry for all these models and for 5 systems that we have available. The final challenge was then to come up with something practical. And here is indeed a practical approach, but highly detailed. At this moment, we are working to try to make it even more practical by averaging over different systems if the errors we make remain acceptable. This is a work in progress at the moment. Let's now go to interventional radiology. And I want to start first with focusing on the lower limbs, because this is a very frequent exam, and I mean specifically a diagnostic examination of the lower limbs. And I go back to a study that we did in 2008, and I'm pretty sure the concepts and the systems are in fact but not much changed when it comes down to conversion factors. Probably the effective doses are a bit lower now, but the conversion factors would probably still be very similar because or can be adjusted to the filtration and so on. But in 2006, 2007, we did a pretty large study that had several aspects, including the effective dose calculation for angio of the lower limbs. And my student at that moment, Christine Smans, did a very detailed study with going to all these 12 centers, sitting next to the exam, noting down all the different field of views that were used, all the angulations, all the orientations, all the KVs and all the filtrations and so on and so on. And she came up with site-specific conversion factors for effective dose. Here is the proof that she indeed accomplished this. What you see in this graph are the 12 centers. You see the effective dose following two documents. In 2006, this was still pretty hot. And then the DAP for the same examinations. What do I want to show here in this graph? Well, in fact, two just examples to show. They are not put in a specific order, but it's just easier to see if we compare center 2 to center 3. You see that the relationship between the DAP and the effective dose is very different. For instance, these centers, here they have the same DAP, but the effective dose is pretty different. And you see here the most extreme case where a certain DAP and effective dose are in fact linked. And the DAP is here with this line here, the effective dose are the bars. And this center 12 is is an outlier. And we find out afterwards that it is because this center still used our over couch situation. So from this, it was clear that in fact, there are if we do it personalized, or at least for specific groups and specific hospitals, there is some work to do. 15 years ago, this was a huge task, including traveling, time consuming, the DICOM text in most cases incomplete, so you'd better sit next to the system and note down what you could do. We still had overcouch, undercouch, and we picked indeed, or we did then the Monte Carlo simulation to obtain these specific conversion factors. All this, however, can be automated, and that makes us appreciate things like this in one click. Actually, this morning, I checked for the last month, and I get every day where the system has been used. We are in a partial lockdown here in Belgium at the moment, and the total number of examinations is a little bit less here compared to now. Now it is, more back to normal again, but important here is the mean effective dose of like 10 cases here a day, some more, and this is just, with a click at your fingers that the study count is here, sorry. So these are 2 patients a day, that's 4 patients a day. And we just get this effective dose calculated specifically for that room in just a few seconds. With these management systems, we get an astonishing amount of data, relatively easy, even from at home, which at this moment is especially interesting. Of course, it's not yet completely solved. Maybe we can even push into making these conversion factors size specific, ensure the anatomical position is absolutely correct, which is something a dose management system cannot really verify at this moment. Maybe with some AI techniques later on, it must be possible to find out really which part has been imaged, and maybe extending with personal dosimetry would be fine. But now that we have these systems to collect all these input parameters, it was possible to go a step further. And based on the KV, the filter, the orientation of the tube, the geometry of the table and the tube, so the angulation, in fact, the aircom and reference point, with all data available and just applied for every series, it is also possible to start estimating the accumulated dose from the aircom in the reference point. And this is even more amazing, I think. This is 1 year of data, and I took data before there was the Corona crisis, so from November 2018 till November 2019. And you see here that the maximum peak skin dose in our interventional radiology room was here in this point, about 6 gray. We have another point at 5 and a few at 4 and 3. We see an immediate estimate of the number of cases where the peak skin dose goes potentially high. Here is the overview of last month in one cardiology room, and I've now picked this patient here into more detail. And here is the detail we get. This is what's happening on the back of the patient. The patient is laying on the table, obviously, the tube is under the patient, and this is on the prone position. The prone position is basically empty because the tube was indeed used under the table. And normally it comes with this little video that shows series by series what is happening in this patient, and it accumulates for every series, and then we get some nice statistics. Okay, that is the peak skin dose. It is also nice to see, and that's mentioned here on top of that, this calculation was done for an adult phantom of 105 kilo and 183 centimeter high. In fact, when the information is available via different calculations, it is possible to do a more precise patient-specific measurement, even of the peak skin dose. So again, I just repeat, with these dose management systems, we get an astonishing amount of data to be used further. So we started here from these different steps. In fact, for the patient's peak skin dose, it is maybe just climbing up, where we make it more and more patient-specific. We start from just looking at the cumulative air kerma or the depth value, and then we add different types of more specific patient-specific data into this to end up maybe one time, real time, during the procedure, the mapping of the skin dose. These were my 6 examples. Let's now discuss them a little bit into more detail. Personalized effective dose is a broad concept, and maybe we have at this moment to pick the step where we are now or what we want to investigate. It goes from the application of a single size-specific factor using a commercial system up to individualized Monte Carlo calculations. And I think all aspects have their role, and all have also their applicability, because obviously individualized Monte Carlo calculations are at this moment not possible, and probably also maybe, I say maybe, not needed. There are commercial solutions on the market that do Monte Carlo for you. So you give them your CT images, and then you see the dose map. And if you then at some point segment also the organs, it is possible to link these two and calculate the effective dose. A workable in-between solution may be to find in some way or another a phantom that matches the patient, and then you use for your patient the conversion factors that were applicable to your phantom. I think what we should check first, maybe systematically, in this conversion factor development is to investigate where are the parameters with most impact on the conversion factor, and first focus on this. I personally think that patient weight is probably one of the most important, but of course also things like accurate organ dose positioning is important, and the filtration for sure also. I also think that these extensive calculations and the modeling that would benefit from an international approval or from international projects or from group work, because I give you the example of the pediatric exams on CBCC Dental. That was a big effort, and maybe the value should go outside from our team towards the world. But there are also a lot of applications where I would be very happy to use, of course, your ideas or your conversion factors. And there, obviously, publication is very important. I think also that that's a good suggestion to include personalized dosimetry in those monitoring systems to allow detailed studies. I would like to conclude, and I've started here. Personalized dosimetry has several applications, such as better individualized risk estimates in the frame of justification or just to know what is going on with your patient, or for those outlier alerts to avoid that we pick always obese patients as outliers, while we actually, in all these cases, that we forget to find the real errors, which maybe happen at normal sized patients, and that should be solved. And it goes for size-specific optimization process. I think it's logical to the effect, right? But it is for sure a very nice, but maybe a very long way, but probably a very nice way to go. I hope you agree with this. And okay, in our final conclusion, I say potentially there's a lot of research work ahead, and that would probably be helped with specific research grants, and for sure with networking. Why not with all of you? I thank you for your attention.
Thank you, Hilde, for the excellent talk, which is very useful for the future investigators. And it's really a branch which will pick up in the coming years. We have some questions, and I will start first myself. Overall, in summary, you feel that it is a question of getting a better estimate of the effective dose using the characteristics of the patient as well as of the machine.
Yes.
That is what the summary is, right?
Yes. Yes, I think so.
So that it becomes clear that we are not talking of some different quantity than effective dose. So it is a better estimate of the effective dose, right?
Well, yes, Madan, and I feel sorry if I forgot to say it, or in my preparation, I wanted to stress that this new effective dose is...
Can you share your presence so that we can, your picture
Sorry?
is there. You can stop sharing so that...
yeah, okay. Yeah.
Okay, yeah.
Okay, yes. So I forgot to say that this effective dose, where we make it more and more patient-specific, that it's probably the patient-specific effective dose that you have so nicely introduced for us. And I forgot to mention it in my slides with the different steps, but I had the intention to tell it that you give the baby a name, and I think it's fine. It's a good idea.
Yeah, I'm happy to note that, because yes. ICRP is sort of the Dr. Harrison and Colin, who is also perhaps there today in the session. So we three discussed, and it seems that we felt that that is the right way to go forward.
Yes.
And
Yeah.
I see that you are on the same board. You are
Yeah,
on
yeah,
board.
absolutely. Yes, and I'm very happy that yeah, that you gave it a name. But I forgot to mention it here. It was
No
yesterday
problem.
on my slide, and I rechanged my introduction.
No
And
problem.
it
Second
disappeared.
point is we are talking of personalized dose, not necessarily personalized risk estimate, because risk estimate,
Yes.
as you rightly said from the beginning, is a second and subsequent thing. So we
Yes.
are mainly concerned with the dose, and that is the dose
Yes.
specific for the patient. Another point is that Ssde was developed not to use it to estimate the effective dose or patient specific. So I saw in one of your slide that there is a tendency to go from Ssde or use Ssde to reach the effective dose. Is that right understanding?
Yes. I would have to check the literature again, whether there are now papers giving us these conversion factors. When I did last a search, I've not found them yet, but I expect someone will come up with them. We have also conversion factors that are pretty close to this, or who could go from Ssde to effective dose, but I was checking literature from the group who came up with the concept, maybe to then also provide these factors. As soon as there is a paper related to this, it would be good to use them, I think. But at this moment, the CT scanners do not yet give us the Ssde. Our dose monitoring platform has it, so we could apply it. But I would want now, in the meantime, just to push hard. Well, push hard, I don't know. I cannot push hard, but I can just tell to the CT manufacturers that I think it is a very nice thing to have this Ssde. Because first, I think it's already, yeah, it is already better than the CTDI. If you have just a patient on your table and the patient has been scanned, now what we know is the CT, what we see is the CTDI. If we would see the Ssde, we know we are already closer to the truth. It's not yet the organ dose, but it is already closer than the CTDI. So I would find it an interesting feature to have. And then for really the truly Ssde, I agree with some people telling that Ssde is not the patient dose. No, it's not the patient dose. Effective dose, patient-specific effective dose would even be better. But I would think that this Ssde is already very nice in-between step for daily use, so for people in the room, or you as a physicist, if you have some optimization work to do, you go to the room, and if you can then work with the Ssde, you're already closer than working with the CTDI in that process, where you don't have the time to calculate whatever, you're just at the scanner with your test objects trying to improve things. So I would be very happy to be able to use Ssde in my optimization work at these moments.
Right. Thank you. There are questions from participants. How is mean effective dose calculated in the graph of column Y? Is this from the structured report of the modality, or was there a calculation involved?
Okay, the effective dose for the angio room, I think people mean they start from the information indeed that is available, the RDSR, but for every series, the program, the TQM starts from all the information that is available, like the KV, the filtration, the angulation, the field of view. Yeah, that's, and then the software has also tables on the attenuation of the table. And so, and I must also say, I forgot to tell it, that there is an EU project at this moment that compares the different peak skin dose calculating programs. And there the program was very nice within all the limits that have been put, and was actually very close for some of these systems to to the truth. So it starts indeed from, and that is the nice thing, from all the technical data that's available. It uses also the weight of the patient, which in the case of angio is available, because it's not in chest X-ray, it's not, it is 50, 60 patients a day, and people do not type it in. Some patients don't know their weight and so on. But in angio, they have it. It is in the diagram header of the image, so it is available, and it can be calculated patient specific. So it is an analysis using all the data that come in, and using this to pick the right conversion factors and or the outcome and the reference point to go to the peak skin also. Yes, it is a calculation using all the data you as a physicist would use as well if you wanted to do so. Maybe I can give as an anecdote, I had once a PhD student also calculating effective doses for pediatric cardiology. It took him a lot of time to get to these effective dose calculations in a few hundreds of patients. He worked very hard at this. He made also publications on this, so it's highly appreciated. It is cited from time to time. It is not a problem, but it was months and months of work to do so. And nowadays, the same data are now interpreted by a software. So that's just good. Yeah.
Thank you. Another question is, isn't the difference in E effective for the same depth within E effective uncertainty? I mean, he means to say that is the difference in effective dose for the same depth within the effective dose uncertainty?
It is for sure that the effective dose does not only depend on DAP, but depends also on how the different DAP values are obtained. I mean, sometimes it's up to a few hundreds of series that they do in the room, and every series has its own depth value. And for every series, the best conversion factor is chosen. And then all these effective dose per series is added up until the total effective dose is for sure not just one conversion factor put on the total DAP. You have a good point to know what is the error on the effective dose for a DAP in an angio procedure. And we have in Belgium a very nice document that is has been made by on the initiative of our government, which gives effective dose factors for different orientations, for different KV, for different filtrations, and for men and women, for cardiac and abdominal. It can be downloaded from the website of our agency. If you Google on conversion factors, interventional radiology, Belgium, I think you will get it. It would be good to see there what the impact is of technical factors on the conversion factor, and then the impact of patient size on these conversion factors that can probably be obtained from the medical physics paper that I've just shown you, where you see the conversion factors a function of size. So, well, my long answer to a nice question is, I don't know by heart. I've not done research myself into a full expansion of the impact of all the factors on the effective dose conversion factor, but we probably picked the most important ones, beam energy. But it is worth a study to maybe list all the factors and to find out which ones are more important. I had that also in the conclusion slide, that if we start calculating conversion factors, it would be good to first find out which factor has most importance. And but before we know what's most important, we may have to study all of them. So I think this research has still to be done for several applications.
Right.
So, yeah.
Thank you. Another question is for CT personal dosimetry reporting. Is it a good idea to report the dose multiplied by Ssde to the doctor?
Yes, yeah, yeah, it's probably a tricky question. So I do think that if we have to tell something to the doctor, then it is effective dose. But there is a risk that, for instance, a doctor who has understood the problem, if you want, or the issue, that he might start shopping for his patients until he finds the hospital in the region that produces the lowest effective dose. And there then you get me angry, because that is exactly what should not happen, because with a certain dose there will be certain quality, and for certain requests you need a very specific quality. And here maybe I have my background of university hospital, where for every specific request it is determined which scan this patient will get, and sometimes the dose is higher than in another. So it is a bit dangerous. At the other hand, when I teach to the doctors, and I teach quite a bit to not only radiologists, sometimes also surgeons and GPs and so on, I go as follows. I say, you know, what is the effective dose? Well, it is the effective dose. It is effectively what you need. It is something you can use to compare different situations. So yes, if it's a policy of your hospital to publish it and to give the referral doctor this information, I would for sure go to effective dose, and for sure not centigrays, centimeter square, or milligrays, and then all these different units that we are using. No, I think their effective dose is a very nice solution. And okay, I keep on, like I said, I tell them it's effectively what you need. Higher means higher risk, lower means lower risk. Yeah.
Right. Another question is any work being performed on DL networks based on full Monte Carlo simulations for patient-specific effective dose estimation?
I have not understood the first part of the question. What is a DL network? What, of DRL or what?
No. I also don't understand DL networks. So this must be some.
So what is a DL network? Deep learning network, you mean?
Perhaps.
Is it
yeah, deep learning? Yeah.
So, okay, can you please now repeat the question?
Is any work being performed on deep learning networks based on the full Monte Carlo simulations for patient-specific dose estimation?
Okay, yeah, that's a very nice question indeed. Yes, I think a lot of people are now applying their deep learning, artificial intelligence approaches to, for instance, start from a CT scan and segment all the organs and then do the Monte Carlo. Maybe even faster, you give a deep learning network 100 sets of CT scans with the Monte Carlo calculation, and then you just give a scan and this thing estimates the effective dose without even doing the Monte Carlo. I think few groups indeed are working at this. We don't do this at the moment.
Right.
It would be a possibility, but yeah, you need, actually, in order to do so, you need a project. It's not something you can do in an afternoon, so it could work indeed. Yeah.
Right, thank you. Another question is wondered if the estimates on E includes taking into account the age of the system, and old one may be giving higher dose, but practically may not be possible to replace. Not everyone can be like this.
Yes, of course. Well, I wanted to first clarify one thing, which is I have not said anything in this presentation on the quality that can be achieved. And so, yeah, so I mean, image quality, let it be detectability of lesions or whatsoever. So this is for sure, I think, even more important than the dose. And the first priority has to be that the quality is sufficient. And if the dose has to go up because your system is a little bit older, then we should accept this. I think it is better to give quality to our radiologist than to give a low dose to our radiologist. And yeah, if we take, if I am allowed to cite Dr. Hassan Sameh, he would ask, do you dose your patient, or do you image your patient? I think we should first make an image and then consider the dose. So that's one aspect. So my first reply is, don't be ashamed if your doses are a little bit higher, when the reason is that your system is a little bit older or less optimal. It is your first priority as a physicist is to help acquire a good image. Then next to, does it impact on the dosimetry? I think there, in most dosimetry questions, the incident dose goes in, and then you have to specify up to some point technical characteristics of your system. So your tube, the beam, basically. So it's there important as a medical physicist that when you test a system, that you measure these data that you may need later on to do your dose calculation. And if in dosimetry projects you give in the correct beam size and the correct incident dose and the correct filter, I think you can come to a very good estimation of your patient dose. And that is what you offer. And if your doses are higher than what people write in papers, then your first task is not to lower your dose. Your first task is to see whether the quality is sufficient. And if you have an extremely good quality, you can start lowering if you want. If your quality is just what the radiologist is needing, you keep on working with the dose that is required to have a good image quality. And you register and you tell, look, that are the doses. And if one day the system is being replaced, you can then go to your radiologist and say, look, that are the doses we use. If you go for a new system that has dose reduction opportunities and so on, you are going to reduce this dose, and he can take it with him in the negotiation. So I would not stupidly say internationally they are at that level, I lower my dose so that I'm at the international level. No, the task we have to do is check what the quality is first. Yeah.
Thank you. Another question, do you feel it is important for us in medical physics community to decide in which exam or modalities personalized dose estimates are significant, and in which exams or modality it is not much more information than the phantom estimates?
Yes, I agree that it would be good if medical physicists could have an opinion there. So I started this presentation with giving my list of applications where I think it is useful. I would be happy, for instance, to discuss this in a larger group, and to avoid that people start with doubling the work where other applications are not done. It would be very nice to spread the work and to do first relevant things, of course. I don't know who would do this or which group, but I agree that well, sharing the work or sharing conversion factors, or have somebody double check some conversion factors, or compile lists of conversion factors or collect them, that would for sure be a very nice, very good idea. Yeah.
Thank you. There are many more questions, but we are running out of time. Maybe I can put one question across for a quick answer. Could you mention all standard metrics which are currently used in clinic arena and commercial CT scanners? Please exclude research metrics. I think this will require long answer. Another maybe question, have you any suggestion, idea on the way these findings can be communicated to the medical staff? I think you have already covered this. I think that we can maybe, is it still important to determine and report CT/interventional patient-specific dose for patients that underwent RT? RT, if RT is radiotherapy, absolutely, radiotherapy is given to the specific tissue in whole of the body. Few millimeter, few centimeters. Somehow it's a wrong conception people have that radiotherapy patients are getting a lot of radiation dose. The patients are not getting those. The small tumor part is getting. Rest of the human body is as good or as bad or as any other person. So absolutely no question of considering the patients who undergo radiotherapy that they have had a lot of radiotherapy, they have a lot of radiation. So with that, I think we have just completed our time for today, and I wish to thank Hilde extremely very much for your wonderful presentation, sharing your knowledge, and this is a very exciting topic. I'm sure this has created a lot of momentum among the participants today from so many countries, and this will be serving the purpose for which we had started these webinars across. People from across the world can participate. This is the last webinar of this year. We will certainly come back next year. We are debating how to manage the next year webinars. We are wanting to add certain more themes of a closed door kind of a small audience, and all that we will come back after we have decisions on that. With this, I will finish the webinar. Some announcement I can take 1 minute to make. There are many emails I get from people saying that they have got email from me as President IOMP, but they are not really from me. So these are phishing emails. So I will like to say that as President, I never or no president writes any email regarding financial matter to the members. This is done by the IOMP headquarter or at the most treasurer. So if there is any email in which you see my name or even my email address, because the people change that to even look like, so please count it as a phishing. It is not from me. I never write any email. One way to check is when you put the reply button, the email address will change, and then you will know that this was not from me. The name may still remain same because these are people who are experts in manipulating the IT systems. So I thought I will announce this and inform you, because I keep on getting so many emails, people saying that, is this from you? And then I have to tell them not from me. So with that, I thank you once again, Hilde, for your presentation. Thanks to all the participants from different parts of the world. Thanks to Magdalena for coordinating technical aspects. Today, everything went very well. Last time we had some hiccup. So with that, have a wonderful day, rest of the day or evening or good night. Thank you very much, and bye-bye.
I would like to add also my thanks to you, Madan, for invitation. Like I started, and I see here many people thanking me. So I feel like now a big musician having accomplished a big task. Stay safe, everybody. And thank you very much for your kindness.
Thank you. All the best.